Thanks everybody for coming to the trauma session. We're really excited to be here and super excited that the program committee has allowed trauma to be so interwoven into the sessions this year and for us to have a session as part of the main stage. So thank you to the program committee. I'm Regan Williams, the co-chair of the Trauma Committee, and Chris Streck is up here as a co-moderator as the chair of the Trauma Committee. We are going to give a presentation today on blood product resuscitation. Chris and I will not actually be talking very much because we have some real experts up here to give you all the information that you need to make sure you adequately resuscitate your patient. I'm going to go ahead and introduce all three speakers, and then they'll just flow from one to one to one. So first we have Stephanie Polides. I had to make sure I said that right. If y'all know me, everyone says my name's Reagan, and it's not Reagan, it's Regan, so I try to be very careful with everybody else's names. Stephanie is a pediatric surgeon currently at Mayo. She did some really important work during her fellowship on crystalloid resuscitation in trauma patients and has done a number of studies based off of that perspective, multi-institutional study, which was really groundbreaking work for our community. And so she is going to be talking about the identification of shock and using crystalloid as a resuscitative fluid. That's going to segue into Rob Russell, who is the trauma director at UAB. Rob has done a lot of work with blood products and blood product transfusion, and recently was the lead on a conference, a consensus conference on resuscitation of hemorrhagic shock in children. And I was able to participate in that conference, at least from the audience, and it was really great to see people from the blood bank and PICU and trauma and ED get together and talk about how do we best resuscitate our pediatric trauma patients. And he's going to give you some of the results of that consensus conference. And then that will lead into our last speaker, Barb Gaines. She doesn't really need an introduction because I know that everybody knows her. I think that she's like one of the pillars of pediatric trauma and has certainly been publishing and talking a lot about whole blood and the need for whole blood use in pediatric trauma patients, and she's going to give us some information on that. Thank you.
Good afternoon. Thank you for being able to be on this panel with everybody. Not sure I deserve to be up here, but I'm going to talk real briefly about recognition of shock. And first with the caveat that there's no perfect way to do this. We haven't completely figured out, and I think we probably still all miss it sometimes. This is the classification of hemorrhagic shock, which tells you everything you need to know about why it's difficult. Early stage shock in children can present with mild tachycardia, mild tachypnea. These things are not specific. Delayed capillary refill, very subjective. But once you get to the later phases of shock and you start to get hypotension, it's too little, too late. I love this paper by Dr. Leeper and Dr. Gaines, and always think about it. When children are hypotensive in the trauma bay, it's independently associated with worse outcomes. So the hope is to identify them and intervene before they become hypotensive. We have a few things at our disposal to do this. From a physiology standpoint, there have been many excellent studies that look at physiologic-based clinical decision aids that have been associated with surrogates for shock, such as need for transfusion. I won't be able to do them all justice in this short period of time, but wanted to highlight the age-adjusted shock index initially published by Dr. Acker and colleagues in Colorado, which has stemmed a lot of subsequent work, sort of refining that and making some slight changes to use in different environments. You can use these if you have the available data and time, but they are yet to be sort of validated in a prospective fashion, showing that it can change management based on their use. The critical administration threshold, or CAT, this was developed in adults sort of as a way to deal with survival bias in massive transfusion literature, because you have to survive long enough to meet whatever the criteria is. So many of the severely injured patients were not surviving long enough to get to the volume at 24 hours or the equivalent of the 40 mLs per kilogram. So in adults, it was described as greater than 3 units in 60 minutes should prompt activation of massive transfusion, and is also a way to adjust for this when you're doing research. Dr. Morgan, Dr. Leeper, Dr. Gaines also recently published the critical administration threshold in children. Greater than 20 ml per kilogram in 60 minutes should prompt activation of massive transfusion in consideration of any hemorrhage control procedures. The nice thing about this is it can be easily applied. It does require recognition that the patient needed blood to begin with, though. And we also thought that you can't really talk about recognition of shock without talking about being able to act on shock once you recognize it. This is an amazing paper, highly recommend a read by Dr. Bird and team, Time is Tissue, Barriers to Timely Transfusion After Pediatric Injury. So sometimes it can be hard to identify it, but then once you do, there can be many delays on acting on it in children. This is some composite adult data showing that with every additional 10 minutes until the first unit of blood is transfused, there's an increase in mortality. And the reason it is so hard in children to identify shock and act on it is right here in this pie chart. These are all the injured children in the National Trauma Data Bank. The red part are those who received blood transfusion, and the really tiny one are those who were massively transfused. So this is so relatively rare in our practice. I think that's why it's hard to act on, and then when it does, it happens, there can be delays. So that paper explains it much better than I will, but just little things like IV access. If you have people who are familiar with doing it in injured children, that's great, but if not, being facile with intraosseous IV access can really save a long time in being able to start your resuscitation. You might have blood available, but is it ready to go in right away? It can take a long time to get into the infusion pump and then actually get to the patient as well. These are precious minutes. And then, even little things such as the pelvic binder. We needed one recently, and it took longer than I would have liked for us to find it and know how to put it on properly because, again, these things just don't come up very much. And then lastly, just to touch on function of the team, there's a growing body of literature on team science and trauma, which is great. Closed loop communication was associated to faster time task completion in pediatric trauma resuscitations. Additionally, when task completion was correlated with number of people in the room, they actually identified that 7 people at the bedside, 13 people in the room was associated with the most tasks completed in 2 minutes. Less than that and more than that was worse. So crowd control is important. And just one final thing, trauma homework for the whole team I think is really important when you need to be ready to act in something that happened so rare. Simulation and including contingency plans for things. We had our blood infusion pump wasn't working one time recently, and someone jumped in and started push-pulling blood into the patient, which was amazing. Debriefing, and sometimes that can include video review, and these things all have data to support their efficacy and helping your team resuscitate the patient faster. So now my colleagues will talk about how to resuscitate. Thank you.
Thank you. I appreciate the opportunity to present some of the recommendations that came out of the Pediatric Trauma Act Hemorrhagic Shock Consensus Conference. I have no disclosures. So this conference was held in Birmingham, Alabama in the spring of last year. Unfortunately, it was rescheduled on three occasions due to COVID, but finally it happened. I want to quickly recognize the participants who put a lot of work into preparing for the conference with the literature review, especially Joe Esperaz and Aaron Beckwith, who are currently pediatric surgery fellows, and Peter Abraham, a current UAB surgery resident. Also, the multidisciplinary consensus committee, who did a significant amount of work before and at the conference to help shape these recommendations. They were from pediatric critical care medicine, pediatric surgery, pediatric pathology and hematology, emergency medicine, and pediatric anesthesia. The product of the conference was published as a supplement in JTACS in January of 2023, and here's a QR to the supplement. Prior to the conference, we standardized PICO questions that were crafted specifically and only for pediatric trauma patients that are in hemorrhagic shock. So all these recommendations are only in those patients. A literature review was performed, and at the conference, these questions were discussed, hotly debated, and recommendations were voted upon utilizing the Delphi method and written up for publication. An important comment on the hierarchical wording of the consensus recommendations. We put very careful consideration into wording and the strength of the wording based on the strength of the literature. So as you can imagine, based on the overall quality of the existing pediatric literature on this current topic, a majority of our statements were worded reflecting a lower hierarchy of certainty. So we broke up our recommendations into those regarding pre-hospital care, resuscitation, and the use of hemostatic adjuncts. So despite, in the pre-hospital setting, I just wanted to highlight several recommendations. Despite the adult recommendations suggesting the benefits of permissive hypotension following trauma, we recognize that children have a significant ability to compensate until very late signs of hemorrhagic shock. So children may not experience hypotension until 30 to 45% blood loss volume. In addition, in a pediatric polytrauma patient with head injury, this strategy would not be recommended. As many in the audience may already be doing, it is reasonable to utilize pre-hospital blood product transfusions by out-of-hospital emergency medical services. The literature demonstrates that it's feasible, safe, and is not associated with any adverse transfusion-related events. As Dr. Politis stressed, early recognition of shock is paramount, and moving the resuscitation timeline forward, I believe, is very important. Although this seems very intuitive, especially with the emphasis on stop the bleed training and with prior pediatric trauma position statements published by Drs. Cunningham and Joffrey, we recommend use of tourniquets by individuals of training. Although the literature is limited, the studies evaluated demonstrated in children with tourniquet use that there was decreased crystalloid administration, decreased transfusion requirements, and a survival advantage if applied before the onset of shock. In addition, there were very few reported limb-related complications related to tourniquet usage. As we resuscitate pediatric patients in hemorrhagic shock, we suggest prioritizing the utilization of blood products over crystalloids for resuscitation. This is in line with the updated ATLS recommendations of limiting crystalloids and making an earlier move to blood products, and in agreement with the East Multicenter study done by Dr. Politis and others, which demonstrated increased odds of mechanical ventilation, more intensive care unit days, and longer hospital stays in those children receiving increased crystalloid boluses. Although we do recognize there are studies demonstrating conflicting results in regard to plasma and platelet ratios in children and the challenges when studying this question retrospectively, on our assessment of the literature, we felt the best studies favored these recommendations. When utilizing component blood product resuscitation, we suggest targeting high plasma to PRBC ratios to minimize the plasma deficit. In addition, targeting high platelet to PRBC ratios to minimize the platelet deficit. A brief comment on potential utility of including deficits versus ratios in future studies. Due to the limitations of some pediatric studies based on the number of blood units, units of blood products, the variability of some pediatric studies with units and unit estimations in the study databases, the concepts of deficits may provide more of an accurate assessment of actual weight-based transfusions than unit-based measurements. Finally, if available, use of low-titer O-whole blood might be considered over individual blood components, for which Dr. Gaines will touch on shortly. The literature concerning utilization of hemostatic adjuncts to include TXA, Amicar, PCC, factor VII, and calcium in pediatric patients was also evaluated. The best studied adjunct, of course, is TXA, and there's certainly more study needed for TXA in pediatrics. But based on the assessed literature, the empiric use of TXA within 3 hours of injury might be considered in a pediatric trauma patient in hemorrhagic shock. The literature off which we base the consensus opinion is seen here, all relatively small retrospective pediatric studies. In the 3 studies, 2 in a combat setting and 1 in the civilian setting, we believe were best designed and best controlled for biases. TXA was independently associated with decreased mortality. There's still much more work that we need to do here, and this was the reason for our weak wording in this recommendation. Finally, I'll briefly comment on the use of viscoelastic monitoring. As we all know, most centers do not or will not have the ability to use and visualize rapid tag, which is the ability to visualize this as the resuscitation is ongoing at the bedside. So if the testing is collected and sent to the lab and 15 to 20 minutes later it's resulted, this may not accurately reflect the status of the patient's current resuscitation in real time. There is literature demonstrating that viscoelastic guided resuscitation may lead to utilization of less PRBC usage and plasma volumes, less coagulopathy at 24 hours, but no differences in mortality have been demonstrated. So in essence, you need to assess your local situation, what resources you have, and what your team's most comfortable using to demonstrate coagulopathy or cessation of coagulopathy. This may be most helpful when you move away from the massive transfusion and start a goal-directed strategy in resuscitation that may be tailored toward each patient's needs. As I was limited in time, I'm not able to fully detail all the clinical recommendations and consensus recommendations made. I'd encourage you to review the manuscript and the literature we evaluated and the rationale for our decisions. I appreciate the opportunity to discuss and happy to answer any questions at the conclusion.
Alrighty, so I'm going to talk a little bit about blood. That's what I do. So I think what we've sort of heard is that to start is, what should we be doing? So we need to recognize that someone is in shock. We need to minimize the amount of crystalloid that we're giving them. We need to stop the bleeding, and that probably, maybe that should be the top thing, but hemorrhage control is the most important thing. We want to transfuse. There's at least some data that say that we should transfuse blood products and transfuse them in a one-to-one fashion. We already heard a little bit of the controversy regarding TXA, but at least consider TXA. But of course, the challenge of all of this is that products are not often available simultaneously. You have to get them. You have to figure out how to get all those things into the patient. And there's the potential for error because you're given all this stuff. So the potential solution, or what I like to say is what old is new again, is whole blood, which is basically a conveniently pre-mixed package of red cells, plasma, and platelets. Isn't that nice? It's all mixed up together. You don't have to do it yourself. These are just some selected pearls from the adult literature. Basically, over the past, probably since 2012, for the military experience and up through the past several years, there have been a number of studies that have sort of suggested that whole blood resuscitation may be better. They've shown that it's feasible, might use less blood products, and may be potentially associated with a survival advantage, at least in the military personnel. What I've also highlighted up there is that if you look carefully, you'll notice that there are different products that are being given all the time. Some of it has a platelet-sparing filter, some of it doesn't. Some of it's warm, some of it's cold. And so just keep that in mind when you're looking at this literature. Is it worth it? This was a study that was recently published in Annals of Surgery. It was presented in American Surgical. It was presented in Annals, or it was published in Annals in 2022. It was a multi-center civilian study of 14 trauma centers, non-randomized, that showed a really significant reduction in mortality when whole blood was used for initial resuscitation. Like many things, it was a non-randomized study, but the Kaplan-Meier curve is pretty impressive. So it's like everything else, a balance, right? The benefits of whole blood, it's probably more physiologic. They're bleeding blood, we're giving blood. That sort of intrinsically makes sense to us all. Potentially fewer donor exposures. You're getting one bag of whole blood as opposed to multiple bags of different stuff. It is a decreased risk for medical error. You're grabbing one bag of stuff instead of multiple. And it's really easy for nurses. Again, one bag, one IV, in goes the stuff. But there are some barriers. First of all, what is the potential risk? The risk is hemolysis because you're giving potentially, particularly to a non-O patient, you're giving potential antibodies, and so that they could have a hemolytic reaction, and that's the biggest potential harm from whole blood. If you're giving, there's RH sensitization issues, and I'm not going to go into today the RH issues, but if someone wants to talk about it, we can talk about it. But RH is an issue. O negative is a pretty rare blood type. O positive is really common, and then the questions of whether or not to give O positive blood. It does require specially prepared units. This is a big issue for the blood banks and the blood bankers because they have to specially prepare these. As in all of healthcare, blood banks have had a real decrease in the number of technicians who are working at them, and the idea of adding a new product really has stressed many blood banks out significantly. There's a potential for waste. It doesn't last as long, and so one of the reasons we have component therapy is because you can put preservative and you can store stuff for longer. And when we're using whole blood, it doesn't last for as long, and so then there is the potential for waste. But the real, elephant in the room is this stuff better? Like we've gotten a system that we've used and we know how to use components. Is this whole blood any better than what we're doing? So we've been looking at whole blood use, and we've been using whole blood in pediatric trauma resuscitation since 2016 in kids in Pittsburgh. And so we've been we've done it in a pretty stepwise conservative fashion, and we've studied it. And so we've looked at safety issues, and these are just graphs to show that we didn't have significant hemolysis in our patients who received whole blood. We looked at some secondary outcomes, so maybe we didn't see a hemolytic reaction, but did we see end organ damage that could be attributed to hemolysis, and we didn't see that. We used some propensity matching to compare the patients who received whole blood to those who had standard resuscitation, and then we looked at organ dysfunction. Again, we're trying to see if there are any differences or any adverse events, and again, there was no difference between the groups. There's been a lot of concern that cold platelets might not be as good as warm platelets. And think about, about how platelets are treated. They're very special little beasties. They live in the blood bank, they are warm, and they're gently agitated all the time. And now we're saying just throw them into the blood bank refrigerator and don't do anything to them. And so there was a question about, do they actually work? And so there had been in vivo data to suggest that they're actually stickier when they're cold. They don't last as long, but they might be stickier. And so we did a little study where we compared in patients who received, had a platelet count before receiving whole blood and after receiving whole blood, and a TEG looking at functional platelet, so strength basically, and the MA is a measure of strength and a platelet function. And we looked at that before and after they received these cold platelets versus components, and it was the same. So it suggested that our cold platelets were working at least as well as the warm, gently agitated platelets, and that this was should not be a significant concern. The second thing that people often will talk about is that we use a platelet-sparing filter that takes out the white cells. Remember, if you give white cells to someone, you might get a transfusion febrile reaction like a graft versus host. And so we do use a filter, and people were concerned that maybe we really were filtering out the platelets, and this again suggested that we were not. And then finally, we had a lot of questions. Well, what about the really little kids? Like, okay, fine, bigger kids, who cares? But what about those little ones? And we basically looked at a cohort of kids that we had that were less than 20 kilos. And so the median weight of this particular population was 12 kilos with an age of 29 days to 5 years. And we saw no transfusion reactions, hemolytic reactions, or any adverse events in that small subpopulation. And what is super cool that I found out when I was there last month is in Salt Lake, not in the Salt Lake City, but the neonatologists, when they're doing resuscitations outside the main hospital, are actually using whole blood for neonatal resuscitations, and they feel that it has been very helpful for them. So again, I don't think that we don't have a lot of data, but there is no data to suggest that younger, smaller children would not benefit from whole blood. So our program's evolved. Initially, we were very conservative, and now we're giving it to pretty much everyone, and a maximum volume is 40 cc's per kilo, and that's probably sort of artificial. It's almost based on how much whole blood we have. So I wish this was a survival Kaplan-Meier, but it's not. But this was our first published whole blood experience, and basically said that we were giving it to really sick kids. But what this Kaplan-Meier curve is it's an efficiency chart, and it's basically showing how quickly we could give a balanced resuscitation to a patient using whole blood versus how long it took us to do that using component therapy. And we're in a hospital that has red cells in the emergency department. 24/7, we have thawed plasma, but it lives in the blood bank. And then we also obviously have platelets, but it still took us about 216 minutes to give a balanced resuscitation, even though we thought we had a pretty well-oiled machine. And it took 16 minutes to figure out that the kid needed the whole blood, spike the bag, and give it to the kid. So our initial study basically showed that it was safe, we didn't have reactions, but it was also very efficient. Then we started looking at some outcome data. This is our first study that we published, and this is looking at surrogate outcomes. But basically, the top is that we could resuscitate shock more quickly. So the patients who received a whole blood resuscitation had a lower base excess at 24 hours than those who did not. And they also had a lower INR at 24 hours. And I think that second one is sort of interesting because what we don't have are the interval time points. And so did we resuscitate or correct an abnormal INR, or did we prevent them from getting coagulopathic to begin with, which I think is really, for someone who has an interest in that, sort of something that I'd like to know a little bit more about. So there has been some data. So survival advantage, that's the holy grail. And this is using TQIP data, which is the trauma quality improvement data, so sort of NISQIP for trauma, and looking at a cohort of kids, and basically under 18, and basically showed that there was no survival advantage using this database or this data set. Although they did find that patients who received a whole blood resuscitation required fewer units of blood, and so used less product, which may, again, be an outcome that is important given that blood is a rare product, or at least a very valuable product. But there was no difference in mortality using this in this study. We did a propensity match study, and we looked at kids who had received massive transfusions. So we said, okay, what we're really interested in is those kids who might benefit the most from having a whole blood resuscitation. Those are the kids who are actively bleeding and required a massive transfusion. And in this cohort of children, when we used propensity matching, we did show a survival advantage at, at 28 days, at 72 hours and at 28 days. And the graph on the bottom sort of is showing how kids died. And so the early deaths, half of them were hemorrhagic, and then the later deaths were all TBI related. And that just sort of is another thing that makes our pediatric population a little different than the adults because we have such a high proportion of kids with TBI. A military group, again, using a different product than what we're using. We're using cold stored whole blood, but they were using fresh whole blood, and they showed a pretty significant improvement in mortality using whole blood resuscitation in a military cohort. So I just want to, again, I've been a big proponent of whole blood resuscitation, and I totally believe in it, but I also think you have to look at the literature, and you have to recognize that it's not great. It's retrospective. There's data quality issues and a fair amount of bias. There are lots of different populations that people are talking about and sort of lumping, penetrating versus blunt, and then where's the role of TBI, the type of center, adults, pediatric centers, mixed, military, what blood product is being used, fresh blood, cold stored, whether it's been leukocyte reduced or not, use of adjuncts such as TXA, and there's also variable volumes of whole blood being administered. When we first started doing this, our maximum volume was about 20 cc's per kilo, and you got to wonder, in terms of mortality, is 20 cc's per kilo of anything going to affect mortality? So I think what we can say is use of whole blood is efficient. I mean, it is prepackaged. It is an efficient way to empirically achieve a balanced resuscitation. Cold stored whole blood in children appears to be safe. We have not seen any signal of a lack of safety. The data suggests that it results in most studies that it results in lower total blood product administration. Again, a potential advantage whether or not you reach that holy grail of survival. And there may be a survival advantage to whole blood use, although the exact product and population of kids who would benefit the most is not really clear at this point. So the next frontier is the randomized control trial of whole blood versus component therapy. Many people are in children's hospitals that will be participating in this study. They're in the final contracting stages with BARDA, which is a federal agency whose initials I can't remember exactly what they stand for, but the trial is being funded at about the level of somewhere between $30 and $40 million. The other issues that we are sort of interested in is pre-hospital administration. We know that the earlier you resuscitate someone, the better they're going to do, and so clearly many of our children arrive at our pediatric trauma centers quite late in the course, and so pushing out blood earlier is probably going to be one of the ways that we're going to move the needle. And then I've always been a little bit interested in other things like freeze-dried plasma, a product that you can, in a small hospital or a critical access hospital, they can have on a shelf, reconstitute it if they need it, and give it to a patient, because these hospitals are never going to be able to have blood in them. So just something else to think about. And that's just sort of my team.